see the scar here, which is about 20 years ago. Then we did a skin sparing mastectomy, removed the nipple and the areola complex, and replaced it with tissue. Implants can also be used as opposed to a tissue from our bellies. The implants can be either saline or silicone, whichever the patient prefers. Some patients like this option because that gives them an opportunity to choose what size they want to be. This is a woman that on her, again on her right, your left, she had a mastectomy with the implant. The implant was placed in the other breast as a means to augment the other side, but she did not have a mastectomy on the other side. This is a patient who had a skin spray mastectomy with implants, and then she had nipple reconstruction, so she opted to have the nipples removed. Next picture. This is the same patient from the side view. And this is a patient that we did a nipple sparing mastectomy on with implant reconstruction. This is her before picture on the left and her after picture on the right. This is a patient that opted to do this for prophylactic reasons. She's a BRCA positive patient, so she opted to do the prophylactic nipple sparing mastectomy, and she had a very nice outcome. Other therapies that patients will need, they may need chemotherapy. We can determine that based on the Oncotype DX study, which determines which patients really need chemotherapy. And then targeted therapies would be tamoxifen or aromatase inhibitors, which block the estrogen receptors, which can sometimes stimulate cancers. And HER2 is another protein that can stimulate cancers, so we can treat those with Herceptin. And with these targeted therapies, we've been able to make a huge impact on improving the survival outcome of patients with breast cancer. Just a quick word, because I know we have to wrap this up, but a quick word about hereditary breast cancers. As we spoke about earlier, breast cancers and ovarian cancers can be, patients can be at very high risk of breast and ovarian cancer if they carry the BRCA1 or BRCA2 mutation. This is passed on by an autosomal dominant, so if you carry it, then your children have a 50% chance of carrying it, or your brothers and sisters have a 50% risk of carrying it, and both men and women can be carriers of this gene and both be at risk. Essentially, the risk for women who carry the BRCA mutation is 87% over a lifetime, which is very high compared to 11% for the general population. And for ovarian cancer, it may be up to 44% for patients with the BRCA1 mutation and 27% with the BRCA2 mutation. So there are people that really should get tested so that we can identify these patients that are very high risk. Those are patients that have early onset of breast cancer, so they develop breast cancer below the age of 50, especially below the age of 45. There is a presence of breast cancer in multiple family members. If they have, their age of onset is before 50, and then they have one relative also that had breast cancer or ovarian cancer at any age. Breast and ovarian cancer in the same woman, or women that have bilateral breast cancer, and women of the Ashkenazi Jewish heritage, and also families that have, where men have breast cancer. This is done as a blood test or an oral test where they just take DNA from your mouth and swab. And it's done, medical insurance can cover it, depending on your family history. It's best done if we do this through a genetic counselor, so they can really go through your family history. And for patients that are BRCA positive, their options are to increase their screenings, both for breast and ovarian cancer. For breast cancer, we would include MRI screening. For ovarian cancer, transvaginal ultrasounds. Chemoprevention, which means medications. We can give tamoxifen to prevent breast cancer, and we can also give birth control pills to prevent ovarian cancer. Or prophylactic surgery or preventative surgery, which means doing a bilateral mastectomy with reconstruction, which decreases the chance of developing breast cancer by more than 90%. Or if women don't want to do the mastectomies, they can remove their ovaries after their childbearing years or around the age of 45, and that not only decreases the risk of developing ovarian cancer by more than 90%, it also decreases the risk of developing breast cancer by more than 50%. So that's basically for the high-risk patients. So ultimately, prevention is the best medicine. Unfortunately, many women do things all right and they still end up with breast cancer. But it's so important to know your family history so that you can let your physicians know what your risk is so they can screen you more appropriately if you're a high-risk patient. Avoid hormone replacement therapy. I have a lot of patients, a lot of women don't like me because I always tell them get off the hormones. But hormone replacement therapy has been definitely implicated in breast cancer for postmenopausal women. Exercise is important to decrease the fat stores and maintain a healthy diet. It's rich in omega-3s, which has been shown to be beneficial to breast health and preventing breast cancer, antioxidants, less red meat, alcohol moderation, and soy as well is a hidden danger. So do not use high amounts of soy products. I know we're running out of time. I'm sure we've taken up the room. But if anybody has questions for any of us, please.
I just wanted to ask you, breast calcifications, are they anything to worry about? My OBGYN seems to be concerned. My breast facility doesn't seem to be so concerned. I don't even know what they are, or if there's anything you can do to stop them, or...
So women can develop calcifications. This is probably one of the most common things that we see on the mammograms. Women develop calcifications in their breast largely by just the turnover of cells in your breast as new cancer cells develop and old cancer cells die, or sometimes even fibroadenomas will develop calcification. Many calcifications are benign, and we can easily identify the benign calcifications. So the radiologist will tell you, oh, I see calcifications, but they're benign, nothing to worry about. The calcifications we do worry about are the calcifications that are what we call microcalcifications. They're very tiny and they develop into clusters. And when that happens, those clusters of calcifications may be an indication of breast cancer. It depends on what those calcifications look like individually. It also depends how they're clustering or how they're layering in the breast. So we really look at the characteristics of those calcifications, and then the radiologist has to make a determination. Sometimes they'll say it's BI-RADS 3, or they'll call it probably benign, which women go, thanks, that's comforting. But actually what they're saying is that 98% of the time, those are going to be benign and nothing to worry about, so they don't want to do a biopsy. They'd rather just watch them. And so they'll bring you back in 6 months' time to watch them again. So if they're a little bit more suspicious looking, then they'll definitely recommend a biopsy.
So mammography takes care of that?
And mammography is the best test for calcifications. Ultrasounds don't pick up calcifications unless they're very large, and MRIs do not detect calcifications.
What is the future effects of those prescribed estrogen versus those who didn't take estrogen? In other words, a person over 70 didn't effect on your body versus taking estrogen versus not taking estrogen.
So women who have taken hormone replacement therapy, what we've seen over the is that women that have had hormone replacement therapy have definitely been at a higher risk of developing breast cancer. It's one of the most definitive associations that we've seen for breast cancer. And what we're seeing is that as gynecologists picked up on this, how many years ago? Probably 10 years they stopped prescribing hormone replacement therapy. About 10 years ago, we stopped prescribing hormone replacement therapy, and we've started to see a decrease in breast cancer in postmenopausal women.
Thank you.
I'm sorry, can you repeat that? Right, so women who had children before the age of 30 and had multiple children are at a lower risk for developing breast cancer. And in addition to that, if they breastfed, breastfeeding is thought to be protective for breast cancer, so if you breastfed, it's also a benefit as well.
And how long does it usually take before you come into breast cancer?
It's a kind of a complicated answer because it really depends on the type of breast cancer, how aggressive the breast cancer is. So some lesions take only a year to become 1 centimeter in size and be detected on the mammograms. Other lesions can take 2 or 3 years to grow to become something that we may even detect on the mammogram, or something that a woman can feel. So it's variable, but it can be, it depends really on the type of the cancer and the aggressiveness of the cancer.